don't know how many residents we've got in here this morning. Anybody have, who are the interns and residents that we've got? Anybody willing to stand up? So as John presents this, it just, yeah, I always tried to stay under the radar as a resident too, figuring somebody'd recognize who I was and figure out all the mistakes I'd made. So, but congratulations to you guys. Yeah, I really wanted to start this morning by just congratulating the medicine house staff. I get to round again on Monday. I don't get to do that as much as I used to, but it's really unbelievable the quality of the house staff on the medicine service. And John represents that. Nick Ruoff also comes to my clinic, and it makes my day when those guys come because they bring such enthusiasm and knowledge to the clinic that it really makes me pause when I was trying to think about what to talk about this morning. So many features of transcatheter valves, but really it's the medicine house staff that drives this place, and I just wanted to recognize them this morning before I got too far into this. So congratulations, you guys, and Amy and Mary that have put blood, sweat, and tears into making the program so successful. So by way of disclosures before I start, I just need to identify that we get research funding to do these trials, core valve, partner trial, and direct flow, also supplying research funding to Duke. And core valve is an investigational device, although some of you may have heard that about a month ago, January 17th, it was approved based on the study done in the United States for patients that don't have surgical options. So the FDA has already approved this device for a specific indication, but primarily it remains investigational. So by way of outline, what I wanted to talk about this morning is where the program is. And as I stand up here, there's a group that stands behind me that probably couldn't fit in this auditorium that makes this program happen. And so before I get too far ahead of myself, I want to recognize Chad Hughes and the Department of Surgery that has supported this program. And what I'm going to show today is just a little highlight of the CT imaging that Lynn Hurwitz has been behind. So there's a big group of people in the operating room, the cath lab, and on the floors that support this program. And it's very impressive to me, one of the things I'm most proud of. On Wednesday mornings, John has been to our 6:30 a.m. meeting. We typically now are reviewing 6 or 7 new patients every Wednesday morning in a multidisciplinary group. So every patient that comes to Duke who has aortic valve stenosis and is high risk for conventional surgery gets presented at this morning conference. And you've got surgeons, the research team, interventional cardiologists, radiologists, and anesthesia at that meeting to sort of weigh in on what's the best treatment option for each individual patient. So I should let you know that that goes on weekly here. So where we are is the first step, and I thought I'd go back to the case briefly, the operative mortality. And in years gone by, we would sort of estimate this based on Gestalt, but if Rob Califf is listening, he'll be very pleased to know that we're not just doing it based on Gestalt anymore. So the Society of Thoracic Surgery has a free database calculator that you can Google. And I'm thrilled to see the medicine house staff using it. As I walk around, I'll see somebody on a computer and has this screen up. And they've already caught on that this is a way of calculating risk for their patients that are going to the operating room. And it's not just for aortic valve stenosis. It's for other diseases as well. So typically coronary artery bypass graft calculations, you can do somebody going to the OR for bypass surgery. And as you scroll down this screen, you enter in a lot of demographic data and laboratory data about your patients, and it automatically updates on the right side of the screen what the mortality risk is. And this is a surgical mortality definition of 30-day mortality following the surgery or hospital discharge. So going back to the case that John presented, as he mentioned, there are a number of things in there that go into the risk calculator. So this risk calculation of 7.6% of mortality risk was based on age, coexisting coronary disease, the fact that it was a redo patient, but bilateral internal mammographs is not part of the calculation. Low ejection fraction you can enter, and the magnitude of coexisting pulmonary disease, but you can't enter pulmonary hypertension, so the risk calculator is phenomenal as a tool, but it is just a tool, and there are other clinical variables that are not in the calculator. Here I've shown a few of them, as I mentioned, pulmonary hypertension, but frailty, the ability to ambulate, patient's mental function that's been shown to dictate long-term mortality, and hostile chest anatomy, which is what the case today is going to highlight, are not part of this calculation. And so it still requires a physician to think about using this tool and what other features of the patient are relevant to calculate the risk. So as I end the first part of the case, what would you recommend at this point? Would you just go with medical therapy, start some DIGs for low EF, try to afterload reduce, although the blood pressure was about 110, and start some diuretic and see how that goes? Or would you recommend reduced sternotomy with a surgical valve? That is either a tissue valve, in this case would be most likely, or maybe even a fancy right thoracotomy approach with a port operation like Dr. Glauer and Dr. Gaser are so readily available to do and do a great job with. Maybe that would work. Or she'd just go ahead and say, we'll do a transcatheter valve, or she'd get more data. And this kind of question is what you hope to see on the boards as you recertify, because this is sort of an easy one, because get more data is usually the right answer. So I'll talk now about the two valves that we've been using for the last 3 years, and I'll highlight just some of the features. I don't want to get into great detail about these valves, but transcatheter valves by and large are stent valves, and they share in common the feature of not removing a native diseased aortic valve, but really pushing it to the side and leaving you with a new valve in the center supported by the stent frame. The difference between these two valves, Sapien, that has the longest track record in the US, and CoreValve, is the fact that Sapien is a balloon expandable prosthesis, and CoreValve is a nitinol-based stent frame that self-expands. If you look at some of the other features that differ, the Sapien valve is a much shorter stent frame. The CoreValve much larger. I like to call this sort of the double hourglass. If the Sapien valve has thicker valve material, bovine pericardium, the commercially available valve comes in just two sizes, 23 and 26 millimeters, treating annular ranges from 18 to 25, and has a fairly daunting delivery system currently, although in the next few months this is going to be reduced in diameter. But you can see 22 and 24 French, 24 French about the size of my index finger. It can be put in from transfemoral approaches, but also alternate approaches, particularly transapical was one of the first access points for Sapien, but we can also put it directly into the ascending aorta. It is not useful from a subclavian approach because of the delivery system. The CoreValve frame, self-expanding, is nitinol that's temperature sensitive. So the way we get this compressed in the delivery catheter is it's put into ice-cold sterile saline in the operating room. It makes the system soft. It's loaded onto the delivery system and attached to the catheter by two small tabs that you can see at the upper end of the device. Once it's in the delivery system, this porcine pericardium stent frame is deployed. You can see that it is covered for the first 12 millimeters, it turns out, of the inflow portion of the valve with a skirt of porcine pericardium. So the other thing that you'll see that differs is that this valve sits in a native annulus position. This valve actually sits in a supraannular position. So if you look at these valves by echo with CoreValve, you find that the valve actually sits about 10 millimeters above the native valve annulus, a really novel approach. It has a greater treatment range, annular treatment ranges, the whole way out to 29 millimeters. And because it doesn't require a balloon and is thinner material, it's a smaller delivery system about the size of my pinky. It can be delivered transfemorally and from subclavian axillary approaches, as well as from directly into the ascending aorta. So very proud of our combined operating room cath lab team. And I thought I would show you a couple examples of how this valve is used at Duke. This is the hybrid OR, a radiograph showing the delivery system from SAPIEN. You can see it's a relatively large catheter coming transfemorally. From the other femoral artery comes a pigtail catheter, which we use to take angiograms and position the valve frame. The last catheter you see in here is a transvenous catheter coming from the femoral vein that we use to control the heart rate during valve deployment. And this is the actual valve deployment. You can see that the initial feature is we get a coplanar view with an angiogram that shows the valve plane. We leave the pigtail in the right coronary sinus of Valsalva, inject contrast during pacing of the ventricle at about 180 beats per minute. And during that period of relatively low stroke volume, we gradually and then relatively abruptly inflate the balloon catheter to place the valve. And this is the angiogram after valve placement. You can see it's a relatively short stent frame. The native aortic tissue is pushed out to the side, and you can see the frames exist below the coronary arteries. The valve plane, you can imagine, you can see some of the leaflets, really sits at the same valve plane that the native aortic valve existed. Core valve is a little different. Similar approach. This is again a transfemoral approach with the stent valve catheter coming from the right transfemoral, the pigtail catheter coming from the left transfemoral approach. In these cases, we choose to position the pigtail in the non-coronary sinus of Valsalva, and the pacemaker is a little different. This is a temporary screw-in lead placed from the neck. And the reason we do that is that the core valve conduction injury is higher risk. And so this allows us to have a very stable pacemaker system in place, which also allows us to get the patient up immediately. So a case that we do first case in the morning is usually sitting up in the bed and having lunch when we go see him following this. This is the valve deployment with core valve. It's different in that you withdraw this constricting sheath, and as you withdraw it, it allows the nitinol frame to start to flower in the inflow. It allows the operator at this point, what we call 2/3 deployment, although this one's a little bit more than that, to assess the position of the valve and the function of the valve by TE and angiography. And you can see at this point we think the valve position is pretty good, and we fully release it and it looks similar to this. You may be able to visualize the new valve leaflets, this sort of teepee of contrast around the new valve leaflets, and you can see the sealing skirt goes up to about right here with some of the native valve leaflet tissue pushed to the side. Hemodynamically, these valves are startling. So for someone like me who's lived with hemodynamics in a cath lab with aortic stenosis, this just blew me away the first time we saw this. You went from someone where the shaded portion here, this is a left ventricular tracing versus an aortic tracing. You can see the gradient here quantitated at a mean gradient of 100 millimeters of mercury. And then immediately after valve deployment, within 5 minutes, you remeasure this, and the aortic valve gradient is essentially zero, computers calculating 11 millimeters of mercury. We also pay attention to the difference in the diastolic pressures to really look and see if there's paravalvular AI that's significant. And what you're really hoping to find is a case like this where there's nice separation between the aortic diastolic pressure and the LVDP. If these things are coming close together, then you know you've got more work to do. I want to go now to the US data and show you what I think are the highlights. There's a lot of data out there, but I want to show you the landmark trials of partner A and B using the SAPIEN valve. as a first step. This is really 2 trials, and it began about 6 years ago, published 3.5 years ago now in the New England Journal. There are 2 trials. One is so-called inoperable patients. And inoperable patients are 350 patients that were randomized to either standard therapy, which meant sort of diuretic medical therapy without any intervention if they had no surgical option. Half of those patients received sapien stent valves. The other group was called high risk, so patients that had an operative choice but were deemed to be high risk by 2 independent surgeons at the protocol center. And those patients anatomically were defined as either having transfemoral access or not. And the 2 groups that were treated were transfemoral and transapical. Once that was decided, they were randomized to either an open surgery standard conventional AVR versus transcatheter treatment with sapien. The first trial to come out was the extreme risk cohort, that is the inoperable cohort, again, October of 2010. And this is really a landmark paper in my mind to show proof of concept that stent valves work. This is a busy slide looking at the demographics, but I'll just highlight a few of the features. Mean age was 83 years old. The STS risk score for these 2 groups was well matched at high risk, really very high risk at STS risk of 11%. They all had bad heart failure, or at least 90+% of them had class 3 or class 4 heart failure. And if you look at this, one of the main features of this extreme risk group is really 1/4 of these patients roughly had oxygen-dependent COPD. So very, very high-risk group of patients to be treating. And here's the primary data from cohort B from the inoperable group randomized to medical therapy, sapien transcatheter valve treatment here, and then standard medical therapy here. And you can see the mortality, they paid a price for having been treated. 5% mortality at 30 days versus 3% in the medical therapy arm. But the really important finding was at a year, there was a 20% absolute gain in survival in patients treated with transcatheter valves with sapien. And this is really the most important piece of data from this trial. So proof of concept, we knew that patients with medical therapy, we published here in 1991, patients that didn't have a surgical option at Duke, their mortality at 1 year once they developed symptoms with severe aortic stenosis was 50%. Medically treated patients in 2011 weren't any different. 50% mortality. So we'd gone 20+ years, and the mortality with severe aortic stenosis that's symptomatic is roughly 50% at 1 year. The other things that you notice is that the repeat hospitalization rate much lower, halved by patients treated with transcatheter valve sapien. And then they paid a price in terms of stroke. And so this was the big concern. The transcatheter valve treated group with sapien in the initial trial was 5% at 30 days compared to 1% of patients treated in the medical therapy arm. And that difference persisted at 1 year, almost twice as many strokes in the sapien group. But you see a 4% risk of stroke in this high-risk group just treated with medicine. This is a graphical depiction of that data. Partner B, again, inoperable patients randomized to medical therapy versus sapien transcatheter valve treatment. At 1 year, here's the 50% mortality I was talking about, and the difference persists out here, the 2-year data that was presented. Mortality improvement of about 20%. I'm going to shift now to the randomized cohort of partners, so-called cohort A. 700 patients brave enough to be randomized in a high-risk group, randomized to be treated with transcatheter treatment with sapien or have open surgery. What's the difference in these patients? So if you look at the demographic table from the New England Journal, you look at their age, about the same, 84. You look at their STS risk, they're about the same, 11 or 12%. You look at their heart failure class, it's about the same, over 90%. But the major difference demographically that can be gotten from the table is oxygen-dependent COPD in less than 10% of both cohorts randomized to surgery. So at least looking at the information that can be quantitated, if you went into the heart surgeons and you had severe lung disease on oxygen, they were really unlikely to put you in the surgical randomized cohort. And I think that makes good sense because of the fear of having patients on long-term ventilatory dependence. Here are the results briefly with the randomized cohort, SAPIEN transcatheter valve treatment versus surgery. And the primary data at 30 days, you can see that there's some interesting features here. The mortality with transcatheter treatment, about half of what it was with surgery. But the other important feature is, you remember the STS risk, the U.S. surgical data predicted a mortality of 12% in this surgical group. So the surgeons here got these patients, these institutions that did high volume surgery, got them through at half the mortality rate you would predict from the U.S. surgical database. 6.5% mortality at 30 days was better than anybody would have predicted going into this trial. But the most important data, again, comes at 1 year. And if you look at transcatheter treatment with SAPIEN, 350 patients versus open surgical treatment in 350 patients, it was roughly a dead heat. Mortality at 24% in the SAPIEN group, 27% in open surgery. There were some differences, as you might imagine, in the morbidity of the two procedures. So stroke, again, came out higher with SAPIEN treatment, 3.8% versus 2% with open surgery, and this difference persisted at 1 year. Vascular complications with this delivery system much higher in the SAPIEN transcatheter treatment arm versus open surgery. But despite the complications of vascular complications, bleeding risk still higher with open surgery. And here's a graphical depiction of the Partner A randomized transcatheter SAPIEN versus surgery, looking at 2-year data, and you can see there's some early reduction in mortality with transcatheter treatment, which comes together and really is almost superimposable by 2 years. Well, why is this? Why do you lose some of the mortality benefit as you go on with transcatheter treatment with SAPIEN and Partner? And this is some of the Achilles heel of the early transcatheter valve treatment, and you see here is a graphical format of aortic valve regurgitation. This is really paravalvular regurgitation, inability of the valve frame to seal the annulus. And if you looked at patients that left with none or trace aortic regurgitation versus mild aortic regurgitation, and those characterized as moderate to severe by echo and follow-up, you found that there was a mortality separation where patients with moderate or severe aortic regurgitation did less well over time. So we learned that paravalvular aortic regurgitation was not uncommon with transcatheter treatment in SAPIEN, and it was bad. Well, maybe there's some patient features too that are part of it. And so people looked at the data trying to find out, can you predict who's going to do well even if they have a perfect valve result? So their aortic valve is now functioning perfectly, but they still don't do well. And here is one of the primary findings. If you look at Society of Thoracic Surgery predictions of less than 5% versus an intermediate group, 5 to 15, and those with greater than 15%, you find that transcatheter treatment in this is the inoperable group randomized against medicine, you find that there's really no benefit if you have such high comorbidity and your STS risk is 15%. So there is this idea of now called cohort C patients where they have so many comorbid features that you have to take a second thought about whether you're really going to help this patient by putting him through a transcatheter procedure. I'll move on to the U.S. core valve data, only showing the extreme risk results, and it was randomized in a similar way. Extreme risk, which is really cohort B inoperable, was presented at the TCT meeting in late October, and I'll show you those data. It was a non-randomized protocol. So this was, as this trial was beginning, Partner B got published, and the FDA felt that randomization to medicine was no longer ethical. So although the extreme risk cohort originally had an optimal medical therapy arm, that was eliminated just about a month before the trial began. So anybody considered to be extreme risk was treated with transcatheter treatment with CoreValve. The high-risk cohort is almost identical. That is, it's a randomization versus standard surgery, and I would keep your eyes open. This will be presented in about 30 days. I think the date is March 29th for late-breaking clinical trials at the ACC meeting. So you're 1 month away from seeing these data. Duke was a leader in the CoreValve trial. I just show this slide to show we were second in enrollment in the extreme risk group overall in the United States. And we've treated well over 200 patients of your Duke patients now with transcatheter valve treatment. The demographics of this extreme risk non-operable cohort look similar, 83 years. STS mortality predicted 10.3%. Class 3 or 4 heart failure still greater than 90%. And then home oxygen even higher in this cohort, almost a third of patients on home oxygen treatment with transcatheter treatment in the extreme risk core valve cohort. This is the primary data, and again, there was not an optimal medical therapy arm, and so statistically, they used the partner optimal medical therapy data, and they took 2 standard deviations below that and set that as the performance goal. So you remember 50% was the mortality in the medical therapy arm. The performance goal was set 2 standard deviations low to try to choose a bar that was as high as they thought was reasonable at 43%. And you can see the operative mortality with transcatheter core valve treatment in the U.S., 9.3% at 30 days and 25.5% at 1 year. If you remember back to the Partner B inoperable SAPIEN data, it was similar. Operative mortality was about 30% at 1 year. Not operative, but 1 year mortality was 30% with Partner SAPIEN and about 26% with CoreValve. Where did our Duke patients live? So we're fortunate we had no operative mortality in the Duke group and 16% mortality at 1 year. So it made me feel good that our system was working. These conferences on Wednesday mornings where we had some really brilliant minds in there trying to decide which patient would get treated with what was helpful. The secondary endpoints for CoreValve, slightly lower stroke risk. So you remember with SAPIEN was in the 4 to 5% range of procedural stroke. Major stroke here procedurally was about 2.5, sort of similar to what the surgical cohort was seeing with Partner A. The other feature that I'd say is different about extreme risk CoreValve that's scientifically interesting is if you look at paravalvular aortic regurgitation in CoreValve, it tends to get better over time. This hadn't been seen before, but published last fall. Looking at patients here, they've separated out patients defined as moderate paravalvular aortic regurgitation leaving the hospital at 1 month. And you can see that a lot of these patients actually have a reduction in paravalvular AI with time. The reason for this not totally defined, but most people think it has to do with the self-expanding core valve frame continuing to try to mold with the native aortic annulus. If you look at predictors of mortality at 1 year with CoreValve, you find some clinical predictors that are similar. And again, the biggest one is those patients with marked comorbidities, STS risk greater than 15, despite valve treatment, tend to do poorly in the long run. So I wanted to turn for a few minutes, real briefly, just to show you that we're not satisfied. So the proof of concept from my point of view is there. These valves work, they're good, but can we get better? Absolutely. So where we're going is some new trials at Duke that will now randomize against standard of care transcatheter valve treatment. They will no longer be randomized against open surgery in high-risk groups. They'll now be randomized against Sapien or CoreValve as a approved device. This one is an interesting device called Lotus. Originally Sadra Medical designed this device, US technology. This is a nitinol frame, but it doesn't self-expand. The engineers have got it so that you expand it in a deliberate manner with the catheter using a torquing device on the operator end of the catheter. And you deliberately deploy it, and if you look carefully, it has a somewhat flexible membrane that bunches up around the annulus. And one of the very nice features about this valve is that it's repositionable. So the same way as you deploy it, you can undeploy it. So if you deploy the valve, you then have the opportunity to look at it by angiography and by TE and make sure the valve position is ideal and that there is not paravalvular aortic regurgitation. If you find that it's not ideal, you've malpositioned it, or that there is AI despite ideal position, you can recapture this same valve, reposition it, and redeploy it until you're satisfied. So the early data in Australia looks phenomenal with this device, and we're expecting this trial here in third quarter 2014. Another very novel device that is for transcatheter treatment involves really completely different technology, no longer using a metallic stent frame. This is direct flow, and it has an inflatable skirt in the outflow tract and superannularly. And again, this valve is completely repositionable, so you have the ability to inject this skirt with saline, look at it, and make sure that you like the physiology of the valve you just deployed. And if you don't, then you remove the saline and reposition it, and then redeploy it until you find that it's physiologically ideal. So it gives the operator and our Duke patients the opportunity to get really ideal stent valve results, which should parallel the surgical results that we can obtain with open surgery. So I wanted to leave some time for questions, and it looks like we're going to make that, but I wanted to go back to Dr. Wagner's patient and just remind you that there are some features here that are important. The STS risk is 7.6%, is not daunting for an open operation, but high risk. And this bilateral internal mammary grafts, how are you going to look at that? So CT angiography, and Lynn Hurwitz has been instrumental in this, getting a protocol which he's now published to really educate the rest of the world about how to obtain these images. As we presented these images on screening calls twice a week, each one of our Duke patients on these investigational trials gets put on a national screening call, and they look at our images. They look at the CT, and comment after comment about the quality of the Duke CTs would come to bear. So I just want to give a shout out to Lynn, because obtaining good data allows us to analyze the data properly. And when we've seen outside studies coming in, they're really not the same. Here's a standard view that everybody's used to with CT, and you can see the pleural effusions that we saw on chest x-ray, and you can see the valve annular calcification. If I can bring up the software, I wanted to show you real time what that looks like. So this is a standard view. You can see the frontal axial sagittal cuts, but with the 3D software, you can manipulate these images and look at exactly the valve plane that you're interested in. I don't know, I guess it's not showing up very well on the projector. I don't know if it's feasible to dim the lights a little bit, but what you can do with this is you can choose the aortic valve annular plane that you're interested in. You can spin it and get double orthogonal views to the annulus. And now you can look at the left ventricular outflow tract orthogonally and look here at the LV outflow tract and then come up and start to look at the valve plane. Make detailed measurements of the annulus, measurements of the sinus of the valsalva to make sure you can protect the coronary arteries as you push this valve out of the way. Perhaps most startling are the 3D images. So you can put the muscle and the skin back. You can take it away. You can look at the position of the left internal mammary graft as it comes right underneath the manubrium here. For my medical student son doing anatomy, I was telling him, you got to have this. Well, he already had it. He was like unimpressed. Yeah, we got that. And so you can then spin the images. And you can use a virtual knife to cut away information you're not interested in, and then spin it back. And what you might notice here is here's the right internal mammary graft that's draped right along the right side, the outer curvature of the ascending aorta. So coming from, you can see I've already cut away the internal mammary graft with my, surgeons might have done better than me, but I've already cut away the left internal mammary graft by accident. And the right internal mammary graft coming from a right thoracotomy would be very risky in terms of damaging this right internal mammary graft. So after seeing these images, we were convinced that our colleagues at University of North Carolina were correct that this was risky. And so this is just showing you also that we look at the anatomy and the pelvis for delivery. We look at vessels all through the chest and the pelvis to choose the best delivery route. But after measuring this, what we decided was that he should be consented for the high-risk continued access portion of the core valve trial. He was begun on 20 milligrams of Lasix just 3 days a week. And our research team was unbelievable. They came over, this is a Friday afternoon, they came over and got him consented. At this point, as part of the research trial, his images have to be loaded up on a computer system, including CT, echo, cath images, sent to California. They analyzed the data. On Thursday night, the following Thursday night, he was on a screening call, which we defended the case, and he was approved that night and implanted with a 29 millimeter valve the next Monday through a right transfemoral access. He looks good out there. He's discharged home post-op day 4. And this is a chest radiograph we've seen back in February, a month later. You can see pleural fusion's gone, pro-BNP now down from 5,500 to normal levels. He reported feeling well. His echo as part of the protocol now shows an ejection fraction of 50%. It's trivial AI. A mean gradient across this aortic prosthesis, 4 millimeters of mercury. So we've got 10 minutes. I wanted to thank you guys for allowing me to present my life over the last few years. This is about all I do. My wife said I'm really not good for much else. I want to get John back down here and see if you had any questions about for John about the case or any questions about transcatheter treatment in general.